my question is regarding, you address quality of life as one of the outcomes, and are you also addressing the social aspects in your physical therapy? And what are your thoughts on things like recovery therapies? You mentioned like strength training and aerobics and that sort of stuff. What about recovery therapies that are used for like sports injuries and those sports that are not necessarily physical but more social, such as like power soccer?
I am not sure I've heard the term recovery therapy, so I would need a little better understanding of that. But having said that, I personally believe that anything that keeps anyone engaged and occupied is good for their physical and mental well-being. So that's the basis I start with, and that it do no harm. And sometimes it's hard knowing about harm in the long term versus harm in the short term. I mean, we have patients that have been in the Army, who've been athletes, and the question always arises, the training that they had, did that actually keep them stronger longer, or did it eventually hurt them? And I don't think we have the answers for that, unfortunately. And here it's a perfect segue for the registries. So I'm going to put in a plug for the registry that we've had in Rochester. It's been ongoing for 14 years. It includes patients with myotonic dystrophy and FSH dystrophy. And some of the questions that were raised, epidemiologic questions, cancer-related questions, these are not necessarily going to come out of natural history studies, which are, if you're lucky, 3 years, 5 years. No one wants to fund natural history studies of any length, but this is where registries become important. And the other thing I would very briefly say is the CDC is interested in population-based studies so that they don't just come from a clinic or a region, etc. And they have been funding something called the MD StarNet project, which I'm part of in New York State, which is a population-based study. And I think all these efforts are great at giving us the bigger picture of all the people out there with this condition and the impact of the disease and other factors on their lives and progression.
I have a question for Dr. Boheen and one for Dr. Pandya. For Dr. Boheen, I was curious to know if there's any success in muscle transplants from, like, if I have a sibling who is unaffected by FSHD, could that muscle be taken from a family member and used for the facial reconstructions in any way to help? And for Dr. Pandya, I'm wondering if there's any kind of thought to giving a guide for massage therapy. I've had a lot of success in feeling psychologically good as well as therapeutic for the muscle from massage therapy, but I'm concerned about going to just anybody and if there could be a future guide for that as well.
Okay. So in principle, just as I'm on the face transplant team at Hopkins, and the face transplants have become so sophisticated that you can take bone, muscle, skin, fat, nerves, blood vessel, and transplant it from one person to the other. So in principle, you can do that. But if you do, that recipient would have to be on an immunosuppressor, and that's the problem. We've tried various ways to try to make the recipient as chimeric as possible, so we can take bone marrow from the donor and do all kinds of stuff so that there isn't the need for high levels of immunosuppressants, but there's always the long-term risk. So at this stage, I don't think it will be reasonable to take a muscle from a donor for a recipient, mainly for maintaining tone. But if we work out that immunosuppressive aspect and minimize long-term complications, one can see that being feasible. But I would hope that gene therapy would come before we ever get to that point.
In terms of massage, again, I think massage has been shown to be helpful both physically and psychologically in many, many conditions. And again, if it makes you feel good and it does no harm, go for it. The only thing I would say is there's massage and there are massage therapists. And the things that I might worry about is some therapists who believe in massage for athletic folks, and it's a very hard kind of a massage. And I would, if it hurts, be wary of it. If it makes you feel good, go for it.
One more question.
Okay. I have a question to each of the speakers. First of all, thank you very much for presenting to us. Question to Dr. Pandya about if the studies on exercise and FSHD, if any of them adjusted for the severity of the disease, since there's such great variability, is it possible that maybe exercise actually hurts people with severe, infantile onset, advanced FSHD? A question to Dr. Bohin about facial reconstruction surgery. How long is the recovery period usually for surgical procedures, and what are some of the complications that you encountered? And a question for Dr. Hummel about whether it's possible to kickstart natural history studies with a lot of patient data that has been accumulated by their individual physicians. I understand that there's no uniform standard, so it's very noisy data, but maybe it's not complete garbage for the purpose of natural history studies.
Okay. As Dr. Van Engelen said earlier this morning, we tend to study what we can measure and it's easy to study. So swimming does not get studied, or other things don't get studied. Most of the exercise studies, depending on the mode of exercise, get done in people able to do it. So if it's an aerobic exercise or walking on a treadmill, obviously you have to be able to walk on a treadmill for a certain amount of time to be able to be studied. So that's why, unfortunately, most studies get done on a subset of population, and then based on the findings, we sort of have to extrapolate that. But then we are always wary of people that are more affected, making the same recommendations for them, because we truly don't know the exact benefit or harm that we could do in those populations. And I would love for Dr. Engelen, I think, is still in the room, for him to comment on that part.
Okay. So as far as how long does it take for patients to recover from surgical options that I offered, so on the two extreme spectrums of the examples that I gave, a lot of the non-invasive procedures are really no downtime. The minimal surgeries, for example, tightening the eyelid, tightening the lip, can be done under local anesthesia, so you don't need to be put to sleep for it. And the recovery is usually recovering from swelling and bruising. On the other extreme, when we are transferring muscle, the most complicated portion of it is when you have to transplant muscle from one part of the body to the other. Those patients are on the average staying in the hospital for 5 days. And for this particular patient population, putting somebody in bed for 5 days can be a big deal. And so we try to include occupational therapy, physical therapy, whilst they are in the hospital to prolong, speed up their recovery. So you are looking for an outpatient in-office procedure to a hospital stay of about 5 days. That is if there are no complications. Potential complications are the same ones you see with every surgery: bruising, bleeding, infection. That usually is treated medically. So the most worrisome irreversible change is if I went to take a muscle from one part of the body and brought it to the other part, and you gained in the face but lost from the donor side. That would be the most potential irreversible. And those are preventable things. When we are taking muscles, we are usually not taking the whole muscle. We are taking, because you can't really bring a big muscle on the face. You're really usually taking a small piece of it. So I haven't really seen a donor side morbidity, but you have to carefully choose the donor side to make sure this patient doesn't have it's not going to have a big functional deficit from it. So the donor muscles that we select, we try to make sure that other muscles do the same thing.
I think one more question that I'd really like to go on to our next session.
He had a question.
Dan, did you want me to just answer that one question about the natural history? Just
Yes,
the,
I'll
the
do
last
it.
part?
Yeah. Go ahead.
So, based on my knowledge of natural history studies and registries and others, I think there is a high value in trying to mine data to try to put together some information that may be in disparate sources now. So taking, for example, say the French registry, combine it with Western European countries, American data, even Southeast Asian data of people who have FSH, and combine that all together, I find that that would be a high value. The problem is, a lot of times to put the data together, it's to put it in a data that can make it comparable. So it's hard sometimes to try to maybe define whether it's all FSHD1 or FSHD2, and there may be different variables, but I think there could be some value in trying to bring that together. Also, from the natural history progression, I think there would be a value in trying to assimilate or maybe put together a lot of studies together and try to see if there's something that new could be gleaned from putting all the information or data together. So you would need somebody like maybe a statistician and things like that, and you may be able to get not only descriptive statistics, but there may be something that could be elucidated that having small amounts of data together, you wouldn't be able to find a commonality, whereby is if you have a large enough database. And I think that's the one beauty of having an international, like a registry, versus individual registries the way they are kind of set now. My perspective now is that there's a lot of disparity between all those. So although each one has good ramifications behind it, it may only be limited to how that data was collected, the amount of data, and there may be some differences even in the different populations. Right now I work in biosimilars, which are generics of biologic medicines, and we're finding that there are some differences between, say, folks that live in Southeast Asia, and there's some folks with enzymes and things like that they may metabolize drugs differently, and there's differences and stuff like that. So you have to take into account the geography as well. But I do think that there is a value in that, and I applaud anyone who is working on those type of data gathering collections, because there is sometimes when small amounts of data brought together in larger forms can elucidate different things that could potentially help and speed a cure or find a commonality or a thread of something like that could be towards that.
Thank you. I'd like to thank our panelists, and please stay here. I'd like to have all the researchers come up to the front of the room who would like to partake in our researchers' questions and answers session.